Welcome to Complete Kids Online, friendly discussions about autism and other developmental disabilities. Learn how working together is working better, one conversation at a time.
So welcome back. This is part two for people that tuned in 2 weeks ago. We're here with Alex Young of our counterpart Complete Rehab. If you didn't follow, that was our sister company that does physical therapy for adults. And Alex is one of the lead physical therapists there. The last episode, which I encourage you to go back and listen to, Alex talked all about dry needling. And I'm not going to tell you anything more because you have to go back and find out on your own. But he's going to talk a little bit about pain science today.
Yeah.
And, we didn't cover off on last episode. Alex, just give us a 30-second, 60-second, 90-second thing about how you got into physical therapy.
Okay. Yeah. So,
And what, for anybody out there wanting to become a PT, like what that entails.
Gotcha. So, yeah, I've been the PT for 12 years now. And my original introduction to therapy was actually a knee injury in high school as a patient. And then I got into undergrad and was actually going to work as I want to go into nursing school. So I got a couple years into that and decided I don't actually want to go through all the parts of being a nurse. Have a lot of respect for nurses, but it turns out that job was not for me. So I changed tack to exercise science and I got a degree in PT after that. But so at Complete that we've got here, I run our Mount Holly Clinic. And we mostly see adults. We do see a few kids, not in the same sort of vein that Complete Kids does in terms of the age range or the type of diagnoses, but we do see a few younger patients.
Oh, is that right? I didn't see. I learned something new.
Yeah,
every
so
day. I mean,
in general, my cutoff is if they're old enough to follow directions that I can probably help see them. The youngest patient that I've seen, recently is probably 6 or 7. And it was for like a sprained ankle or like that kind of thing, falling off a skateboard or whatever. We were getting a lot of younger athletes. So especially kids that play like baseball or basketball year round, especially baseball, we want to be really careful with that they don't get overuse injuries.
what's your, we'll do a slight little segue because I'm curious about this. I remember a while ago, John McEnroe, he had a conflict, I guess, with the U.S. Tennis Association. And his thing was they shouldn't play tennis year round, that they should, kind of cross-train, if you will.
Yeah, so I'm a big fan of cross training, right? Fun story, I actually dressed up as John McEnroe in PT school one time, like wig and all, like big hair. So that was a deep cutback. That wasn't a deep brain fold there. But that is something that we do worry about with folks that do a lot of repetitive action in a narrow range of motion band. So if you look at tennis players, if you look at pitchers in baseball, for example, we do want to limit the type of pitch and the amount of pitches. So I'm a big proponent of that. If for any athlete, cross training is going to be important to prevent overuse injuries.
Yeah.
Whether it's just
I think that's where he was going with it too,
And whether it's the right mix of like cardio versus strength training versus like sport specific training, or it's like, hey, if you do tennis, you are tons of forehand, tons of backhand, lots of lateral movement. Like you've got to cross train so you don't get overuse injuries. So you're going to have to end up seeing somebody like me, for example.
Right.
So a lot of my work is prevention. I don't want to have to see you, but if you need it, I want you to come see us, right? So we can get you back out into the world, right? Yeah. But so I'm with John McEnroe on that one. Not so much about like nobody should do year-round sports because that is appropriate for some kids, but you do have to be very careful not to overdo it, and they have to really get a lot of guidance from coaching, athletic training staff, from parents. All have to be on the same page about the intensity and the appropriate levels of action.
Got it.
So one of the big proponents of that is a guy. Let me get that back out. Dr. James Andrews in Alabama. If you ever heard of like a Tommy John surgery, he did the surgery on Tommy John, right?
He's the guy, huh?
Right? As far as I think at the time of this recording, I believe he's still out around. I believe he's actually just retired at the age of 90-something and has just a fleet of other surgeons that follow him around just learning, because excellent surgeon, very personable, big fan of therapy. When I did actually back into the schooling, when I was a PT student at Lipscomb University doing a clinical, he was their team surgeon, so I got to work on some of his patients there. And he has very strong opinions that are very well based in research because he's been doing it for longer than I've been alive in terms of appropriate activity and intensity, especially for youth athletics. He's a big proponent of safe athletics for kids so that they don't burn out at 14 doing something that they could be doing longer and potentially have lifelong injuries about it. Like it's a very serious topic. So if you've got like a 13-year-old throwing too many aggressive pitches with too much elbow movement, like that can cause them some problems.
Right.
But that is something where it is, it's an ongoing debate in the sports and athletic and healthcare community. But I will fall solidly on the side of you can play year round, but you got to be smart about it.
Yeah. Fair enough.
Because again, going back and how that ties into pain science is, a lot of athletes will push through more pain than they really ought to. We hear the phrase "no pain, no gain." That has a very narrow band of applicability. I'm not a fan of that phrase, but no effort, no gain doesn't rhyme. But pain is your body's way of saying, "Hey, something is wrong. Stop and check this out." Right? If it's muscle burn at the 8th rep out of 10 on your 3rd set, okay, be careful. If you're getting sharp pain on the 2nd rep that you've ever done, something's wrong and you need to change. So for acute pain, a lot of folks are a little bit more aware of that because it's a sudden change. Your brain is primed to pay attention to those changes as a threat, like that's an evolutionary advantage to make you yoink your hand back, and your body has systems built in for that. So if you put your, the classic example is
Hand on fire.
Yeah, well, hand on fire. Put your hand on a hot stove, right?
Right.
If you put your hand on the stove, if you have to think, boy, that's hot, that's probably a bad plan. Like, I really don't like the way that feels. I should move my hand. Your hand is ruined at that point. Like your fingerprints are gone, right? If you put it there and you yoink it back, your hand is pulled back before you even realize it because there's a nerve loop that tells your brain, hey, it tells your spinal cord actually, hey, I don't like that, and pulls your muscle back. It also sends a signal up to your brain and says, hey, watch out for like red hot things and don't touch it with your hand, right? So that's a very deeply ingrained reaction to folks. Chronic pain is a little different in that system gets out of whack and doesn't turn back off. So if you have, say chronic pain over 3 months, right, is kind of the normal cutoff for that. So if you have, my shoulder's been bothering me like for 3 or 4 months, or like my back's been bothering me for 30 years, there are certain changes that happen, some of which are happening locally to the thing that's bothering you. Like if my back hurts, right, there's something in my back that's triggering a signal that goes up to my spinal cord, up to my brain that says, hey, something is amiss. I need to pay attention to this. So if you have that going on for too long, the threshold that it takes to originate that signal drops. So if it takes X% stimulus or X% input to send that signal up, now it takes half of that, or it takes a quarter of that over time. On the brain end of that, the part of your brain that pays attention to that gets dialed in too quickly. It gets too hyper-focused on that, and it weights it too heavily in its decision-making process. Your brain is always weighing the information it's coming in about where you are in space, about whether you're moving, about what you see, about what you hear, about what, like the temperature, do you see a tiger in the bushes, whatever. And so it's calculating that to, keep you safe and keep you alive, right? But those systems can get out of whack. And so what happens if you have less input required to generate that signal, and your brain is paying too much attention to that signal, then things hurt that shouldn't. And so I always liken that to like if you catch a red light on your drive to work. If you left early, like you got to have some coffee, like your favorite song is on, you just sit at the red light and jam out. You're having a good time. Like, if you're late, your dog pooped in the crate, because that's what happened at our house the other day. You something that delayed you, like you didn't get to have your coffee, like everybody's driving slow. That red light's a lot more annoying. It's the same light, it's the same drive. That didn't change, but your experience about it changed, right? And so other things that factor into your experience. So when I'm talking to patients, I also want to get a feel for if you have chronic pain. I'm like, okay, what are the things that, the answers or questions that we always ask is, what makes it worse, what makes it better? And sometimes patients have a very clear answer to that. Other times they're like, I don't know, it just hurts. And so neither one is a wrong answer, by the way. That, that the experience is what it is. And the part of your job as a healthcare provider is to not write off what your patients are telling you. They came to you for help. You got to listen to them, right? But part of our job is to help them interpret the information that they have. Because like your brain, people can weight certain information too lightly or too heavily in determining what's causing their pain. And that can be for a wide variety of reasons. And our job as healthcare professionals is to help them sort them out, kind of interpret the information they've got, and then give them something to do about it. And so for those folks that do have chronic pain, we always want to talk about not just specific activities that can exacerbate that, but like, okay, how does it do like when you're tired or when you're anxious or when you're angry? Because especially for chronic pain that is, I'm going to say, not necessarily physiologic in origin, meaning, and this is another good conversation, people say, the pain's all in your head. Every sensation you have is in your head. Right. Because that's where your brain processes it, right? But you do have to be careful how you phrase that to folks to make sure that you're not coming across as dismissive, because we are not dismissive about that. We take that very seriously, right? But your body you don't have a pain receptor, right? Your body doesn't feel quote
Right.
pain. You have nociceptors, you have hot and cold, you have sharp and dull, and then your brain processes that to give you the sensation or the experience of pain. But things like emotion or environment or other stressors can amplify or reduce how painful an experience is in terms of how it processes the signal that comes up from your body. So back to our random guy with low back pain, if it's basic movements that are inconsistently painful or movements that put less physical stress on certain structures than other movements that are not painful, that tells me we've got a mismatch in between what his back is telling him and what his brain is hearing, right? Like there's a communication problem. So for a lot of patients, I say all patients to some degree, but the amount changes per patient. We have to do both, stretching out to tight muscles, strengthening weak muscles, and then recoordinating activity, like in terms of muscular control. But that also comes along hand in hand with recoordinating what their brain is doing, right? And so that's not us doing like psychology or psychiatry or anything, but when people say, talk about the mind-body connection, like those two are the same thing. Your body lives in your mind, right? And your mind is housed in your body. So treating one without the other leaves pieces of the puzzle undealt with, right? But especially for our folks with chronic pain that have persistent pain, like I said, if it's not responded to injections or therapy or activity modification, like what else can we do? And figuring out okay, what other pieces, like the dry needling we talked about in the last episode, other activity modifications. I think Rebecca mentioned like aquatics, like aquatic therapy in the Gastonia Clinic. So if we have somebody who has back, knee, hip, ankle pain that has not responded to land-based because it's too intense or the wrong setup for some reason, aquatics can be both the appropriate challenge for intensity, but a little bit gentler in terms of like the effects of gravity, right? Plus the pool's like 90 degrees. It's like it's nice and toasty. There just feels
like a
good.
sauna. I mean,
It's
a hot tub.
almost. It's not quite hot tub. Like you're not sweating quite that much. Like if you're sweating in there, it's because you're exercising, and people do exercise in there. Like it is, you will come out of there more tired than you expect because water's harder to push through than the air, right? But because it is that different environment, sometimes your brain doesn't make assumptions, right? Again, it's just not folks making conscious choices. This is happening below their ability to choose that. But that's still something we can affect with therapy and something that we can help retrain them to do. So as much as we're retraining, you to pay attention to where do I put my feet, where do I put my knees, how do I hold my torso when I'm going from sitting to standing or picking up, a 50-pound bag of dog food or whatever, we can train certain parts of your brain to be more or less receptive to those signals by, repeated or graded exposure. And that's an equally important part to therapy for folks that doesn't always get addressed or doesn't always get explained, because for patients knowing why we're doing what we're doing is equally as important as the what we're doing and how we're doing it, right?
So is that the same thing, Alex? Like I know I've had this in the past, and I've heard of other people. So I tore up a meniscus pretty good, and I didn't realize it. So obviously, your body's favoring that body part. So then I started to have hamstring problems and hip problems because your brain is doing things, right?
That is that's a related example, yeah, for sure. So if I have something that's causing my knee to not bend correctly or not accept the weight of my body as I'm walking on it, right? I'm going to shift my weight off of that because it hurts. Well, now one leg,
even if you don't realize it.
Yeah. So either intentionally or not, you're going to shift over, and your stride length is different, like how long a step you take, where you land on your foot is different, the amount of rotation your hips have to do is different, and now it doesn't match side to side. The rotation your back has to do is different. Now it doesn't match side to side. And so if you are not aware of that, especially if somebody falls, when I tore my MCL in high school, I fell in the middle of a drumline competition of all things. So that was a single incident, right? Whereas other folks, if you get smaller tears where it's like the edge of a raggedy carpet over time, something finally just nicks it and grabs your attention, that process is a lot slower. So then those changes aren't as obvious to the person experiencing them, and you just well, my knee hurts. Like they may even come in for they come in like, hey, my back hurts. And I watch them walk, and I'm like, well, you are leaning like the Tower of Pisa. Like, can we stand back up straight? They're like, oh, my leg isn't that strong. I'm like, okay, because their brain says push, and both legs are pushing at 100% capacity, right? But if your one leg is way stronger than the other, it's going to either bear more weight or it's going to push you out of alignment, right? And so that's one of the things when we're doing our assessment. We get a lot of odd looks from patients sometimes, but why are we having me do this? I'm here for my knee.
Yeah, it has nothing to do with that. Yeah. You think.
Yeah, and to some degrees, your hip bone connected to the backbone, right? They are connected structures. One affects how the other moves. And so if we're going to do a good job as therapists, we have to look at the whole person, right? So whether they come in just off the street and come in themselves, or the doctor refers them for knee pain, I'm not going to look at just your knee. I'm going to look at your hip and your ankle and your back. I'm going to look at the other leg. I'm going to see how your balance is. And so some of that evaluation happens on the first day. Some of that happens spread out. We have to prioritize, right? But getting that patient's experience in terms of what they're feeling, things that trigger it or help it out, or things that they're not aware of that are affecting it is all part of the investigation that your therapist has to do. And then we also have to explain what treatments we're giving you and what that treatment is supposed to do. Because if I tell you just, hey, do these leg raises and this stretch and like move like this, and that's it, then that's a disservice, really. You need to know why we're doing that, because that helps people integrate that better into how they're moving anyway, and makes both their job and my job easier, right?
Do you think that, or is there a difference? You know, sometimes I've had pain and it just kind of goes away.
Yeah.
So at what point is it become, okay, this is more than just something that's going to go away in 36 hours, you know, that I should go get some help?
So it like many things in healthcare, the answer is it depends. But so it depends on how limiting the thing that you're experiencing is. Like if it doesn't keep me from doing anything, it's like a mild annoyance, it's not there all the time and it goes away after a couple of days. All right, like that's not something you need help with, right? If that happens every Tuesday, right, then I want to know what you're doing on Monday.
Right.
Or if it's something like, we'll get a lot of folks be like, my knee hurts a little bit. It doesn't hurt too bad right now, but like last year it was really bad. Like 4 years ago it was really bad. That's a recurrent problem at that point. So you have something that usually is causing you to do exactly what you said. My knee hurts. I start moving differently. It stops hurting as much, and I slowly get back to what I'm doing. Your body's very good at trying to figure out a way to do something or to heal itself. Our job as healthcare providers is to give you the best environment in which to do that. So like I said, your body's trying to get better, and it does a pretty good job most of the time. Sometimes either it exceeds that, or you don't know what to do or how to change it. Like you need some outside help. And so that's one of the things that'll determine how much we need to see some folks. Some folks we need to see a couple of times a week for a long time. Other folks we need to see a lot at the beginning and then tapers off pretty quick. Other times they're like, hey, it's like mildly annoying. Like it doesn't limit too much, but it limits this specific thing that is important to me. Like, okay, well, let's do it like 1 or 2 visits here and then come back in a month. You've got my card. If you need me in between, give me a call, right? So that's one of the discussions that we have in terms of, when we tell a patient, I want to see you this many times or for this kind of activity, we should be able to tell you why we want to have that particular setup for how much we see you and the contents of those activities and the sort of expected types of progressions. Especially for a lot of patients that have never had therapy before. They have questions, they don't, or sometimes they don't have questions because they don't even know what to ask. After doing it for 10 or 12 years, you have a pretty good guess of what their first 3 questions are. And so I can kind of build that into my conversation with them, being like, hey, but if you're going to ask me this, like, here's some information you're probably going to want to know. And a lot of times they're like, oh yeah, I did want to know that. Or like, that'll trigger some other question that they've got that we can answer for them.
So what's the story? I go out, I'm riding my skateboard, I twist an ankle or something.
Yeah.
I just walk in and to you guys, or how does that work?
It depends on, in America, we got to deal with the insurance, right? So it depends on your insurance. For most commercial insurances, like not sponsored by government, so, Medicare, Medicaid, VA, and then the workers' comp and TRICARE, those kind of things. If you have like most Blue Cross Cigna plans, then you can just walk in and be like, hey, I want to see Alex. My knee hurts because I yeeted off a skateboard. Can I come on Thursday or whatever? And like Rebecca said on that first episode, we give you some paperwork. They lets us get a background on you, get a background on your insurance, so we can tell you good information about like kind of the setup we're going to use, and then we can see you going there. If your insurance does require a referral from a physician, whether that's MD, DO, chiropractor, your dentist, lots of folks can refer you to therapy, right? Right. Then in that case, we coordinate with your whatever provider has referred you to us. And for some folks that walk in just like, hey, I fell off a skateboard, but like, will you tell my doctor about it? Then we'll just fax it over to them as a courtesy. We always try and make sure that any place that we tie into your overall healthcare, we have good communication. So we're always glad to update, a physician or two, and that's just you putting their name on a piece of paper and letting us know.
So in some situations, I don't have to go to a doctor first. I can just go to you guys first.
Yeah. So, because I'm a little bit pedantic about that. So if you are coming to see a therapist, most times now you are seeing a doctor, right? Like it is a doctorate degree, right?
Right.
Now, to be clear, we are not physicians, right? We're not, so that is a separate delineation. But that is what a lot of folks say. I have to see my doctor first. And for some things, if you have, if you have a lot of things tied to that particular condition, you may want to see like a doctor, like your neurologist, your primary care, your cardiologist, or whatever, before seeing a therapist. But with what's called direct access, if you walk into a therapist's office, part of their job as your healthcare provider is determining is what is going on with you something that I need to be treating in my scope of practice, right? So if you come in with back pain that's not had any particular origin, part of what my screening is making sure there's not like, for example, like a kidney issue, right? Because if I can't replicate your pain, I can't make it better or worse. We ask them certain questions that kind of lead us towards another direction. Be like, hey, I'm not the guy you need to see. You need to go see whoever else. We're talking about where we want to refer you out to.
Right.
And for a lot of folks, especially if you're going to see your primary care doctor, they have to know about so many different conditions. Like, yeah, well, that's definitely an elbow problem. We're going to send you to therapy, and that's the end of the conversation. And if that costs you $40, that's not necessarily worth it, right?
Right.
So if we can save people some time and effort and just be another point of entry into the healthcare system, that helps distribute the load both for healthcare providers, but also saves patients theoretically some time and money.
Yeah, I mean, I'd rather just do that than go hear what I already know.
Yeah, it's one less step.
Yeah.
And a lot of patients are, very aware. They're like, hey, like my elbow hurts when I play tennis or when I play golf. I got an elbow problem. Like, all right, then you don't necessarily need to see an orthopedist or like a surgeon or a physician
Tell
before
me,
that.
yeah.
We can see a therapist, and we're glad to coordinate with that. Now, some folks, just because they are more comfortable seeing a doctor, that's 100% fine, right? We are glad to coordinate with those physicians. We have a lot of good working relationships with a lot of physicians around Charlotte, so we have very good communication back and forth with those.
And like
folks.
you said, you know what, this is beyond my scope. You need
Yeah.
to go see an orthopedic
Yeah, exactly.
specialist. So yeah, cool.
And because we do get some folks, so they'll be like, hey, like I might have a rotator cuff tear, and we do have some good testing for some of that. But they're like, hey, I really just want to get an MRI. A lot of times we'll be like, hey, look, you can get an MRI while we're doing that. Some insurances will require patients to see us before they get imaging because of the cost and the likelihood of the imaging telling us something that we don't need the imaging to find out.
Yeah, and as we all know, MRI is not cheap.
It's incredible technology. It'll show you a great picture of your insides, but you don't necessarily need it. And we are finding that we overprescribe it for, especially the folks with insidious onset, like meaning there's not in a car accident, that kind of thing, but no trauma for neck and back pain, because it leads folks to maybe to get information that is not necessarily beneficial to them and doesn't really impact their care. But that is a topic for the next episode, I think.
Well, I'm smelling episode number 3.
Yeah, maybe.
Well, I do appreciate you stopping by, at least giving us 2. I feel like we could do this for about 8.
I mean, I'm glad to come back as much as y'all want to have me.
Yeah, no,
I
we'd love to
enjoy,
have you back. I really learned a lot. It was fun. You're great to have you. As I said, I have a relationship with you, helping me out. So
Certainly.
I just wanted to try to help everybody else. Alex is in the Mount Holly clinic.
Yep.
I'm horrible because I should be able to spout out where we are. Do you know them all off by heart?
Oh, okay. Let's see. Okay. So I'm going to start with my region just because I know them first. Mount Holly, Highland Creek, Lincolnton, and then China Grove. We also have Gastonia right off of Cox Road, and then there's Riverwood over by the airport. Then we have Steel Creek up the road from Carowinds, a fair bit up 160. We've got Pineville, which has a brand new location, so go check them out. Got a brand spanking new clinic. Well, at least new to us anyway. The building's been there for a bit, but we got a clinic there. And then we also have Mint Hill, Harrisburg, and Locust.
You did better than I would have. A lot better than I would have.
More clinics on the way, but that'll be in a
Yes,
future episode
yes.
once they get actually doors open and treating patients.
We'll release that secret here on the podcast.
We have a clinic to show you. You can see it.
And if you want, for more information or to find out if you didn't happen to write those down, just go to CompleteRehab.com, COMPLEAT.
Yep, like the sign there.
Spelled like that, but rehab and not kids.
Or
Thanks
if you
again,
want to
Alex.
sure, there you go.
Alex, we always end the episode. I usually prep people before,
okay.
but I didn't
I'm
prep you
surprised
because we're
now.
going to see how fast you are on your feet.
Oh dear.
As you know, Complete Kids, we have the whole superhero theme. So we end the podcast by asking guests, if you could have any superpower, what would it be?
Oh, I have an
And
answer
why?
right for this.
And why? Oh, I figured you would,
No,
Alex.
because I want because most folks are like, I want invisibility, I want to fly. I want the ability to control probability. Because
Well,
the
that's
probability
a first.
that I
will
can
say
fly.
nobody else is giving that.
Yeah, the probability that I can fly, 100%. The probability that I have $1 million, 100%. The probability that this cup is now filled with the best mac and cheese of my life, 100%.
You know what?
Yeah.
I wouldn't expect anything less from you.
Yeah,
Alex.
so I was just saying the utility of that not being the best superpower, 0%.
Exactly.
But yeah, I can't say that I came up with that. I don't remember who I heard say that. But
That's
I
a
just heard
great
say that
one.
you're about. I'm like, that is the best possible
by
answer.
far.
Because that is your superhero flavor of the day.
Yeah, I like that one.
Plus mac and cheese.
Well, now not only do we learn about dry needling and pain science, we learned about the absolute best answer to give to what superpower would you have if you could have anything in the world.
All right. Well, thanks, Bob.
Thanks again, man. I really appreciate the time.
Certainly.
To continue the conversation, visit the links to our website, Facebook page, or Instagram in the comments.